good morning. On behalf of my co-chairperson, I would like to thank the Organizing Committee for giving us an opportunity to chair this important plenary session. The topic to be discussed is malignancy in organ donation. How much risk we can take safely? As we know, sometimes we do many transplants and malignancy get transmitted, cancer get transmitted after organ donation, and it is inadvertent. And sometimes there's a risk high. We know if we assess beforehand, the risk is high or exceptionally high. So we need screening for that. And to discuss this issue, we have a very eminent speaker, Dr. 𝐵𝐚𝐤 𝐻𝐧𝐢𝐬𝐤. He comes, welcome sir. He comes from UK. He's a director of Edinburgh Transplantation Center. He's a lead clinician in kidney donation program, and he's a lead surgeon, laparoscopic surgeon, multi-organs, and also he's a chair of research, innovation, and technology, and lead clinician for and new technologies, perfusion, organ perfusion. Over to you, Dr. 𝐵𝐚𝐤. You can start your presentation, please.
Thank you very much, and thank you very much for asking me to come here. It's a pleasure to be in India with all of you. And no better way to start the Congress than to talk about donors. And I'm going to start with a challenge for you. Here's the case I want you to consider. It's a fairly standard donor, 59-year-old, but there's only one catch. There's a problem. The donor had a past medical history of colon cancer. So I want you to consider what would you do in this situation and how do you reach to a conclusion. Now, accepting an offer like this, it's a balancing act because you have to consider on one side the risk of tumor spread into the recipient, and on the other side the risk of death on the list or indeed progression of disease whilst on the list, which may put the patient outside criteria. But it is important before we start talking about this to have a clear distinction. There's two different things here, and one is what we call the donor-transmitted cancer, whereby there's already a cancer present, detected or undetected in the donor, and that is transmitted to the recipient, or indeed a donor-derived cancer where the transplanted organ eventually develops a cancer, for example, a renal cell cancer after transplant. Now, this is a very emotive thing, and the press is full of reports of cancers transmitted for the patient, and you'll see there a quote from a patient. It's very important for them. It's something that will compromise what they were expecting to be a successful life after transplant. But equally, the literature is full of reports, and the evidence is low in terms of quality, but there are a number of cases there reporting cancer. So if we look at what's published in the last 40, 50 years, you will see one thing, that the trend is upwards, and this is because of increased awareness and reporting, but also because of the change in demographics of the patients and the population, which inevitably leads to an increased risk of cancer. So let's try and look at some more robust evidence from the registries in terms of how big is the problem of donor-transmitted cancer. And you'll see a number of reports here, some repetitive from the US. But the important message is in column 3. The number of transmitted cancers is low, mostly 0 or single digit. But if they do, they lead to the demise of the patient. So if we were to put this up, the overall transmission rate is really, really low. So it's a small problem. A recent meta-analysis and a systematic review looked at this. Over 2,000 papers reported, and really, if you look at the bottom line, only 73 cases included of various organs transplanted. So the magnitude of the problem is low. So why do we make a fuss about it? Well, we do because it is an important issue for clinicians when faced with such case, because there are a number of issues which you may or may not be aware of. There is a limited information available. The timing of the decision varies for different organs. It's not the same for heart or a kidney. And we also need to know, what does the patient want? What do they think about this offer? So I'm going to take you through some of the most common cancers that we see and see what the problem, the magnitude of the problem is and the evidence. First of all, let's look at melanoma. A recent study published earlier last year, showed really that the numbers are low, but a lot of them will develop melanoma. So it's a significant problem. So this is a higher risk cancer where we really want to be fully aware, and then the evaluation of the donor is important. Breast cancer. It's the most common cancer in women, and here's an analysis done by the French group, which looked at two things. First of all, the survival of patients with any cancer, and then compare that with breast cancer on the right side, and you'll see that if a donor had a breast cancer and transmitted to the recipient, actually the survival is the same. But secondly, they looked at what is the likelihood of transmission. And if you look at the top one first, that's all cancers, there's no difference. But the bottom line is the breast cancer, there's a higher risk of transmission. So they concluded by saying that yes, you could potentially use such organs, but you have to have small cancers treated and a very long follow-up, because breast cancer is latent, is dormant, and therefore sometimes it can occur later. What about colorectal cancer? And this is relevant to the case I've shown you at the beginning. Its risk is high. There has to be some caution, particularly for the early diagnosed cancers, because of potential infiltration and microsatellite transmission, and all others are too high. So consider this when you consider the case I showed you. And there's some anecdotal evidence for recurrence, for the lack of recurrence when you retransplant the patient. Now, a lot of you will work with renal transplants, and it is important to know what about the renal cancer, because here we have another organ that we could potentially transplant. But we need to be aware that cancer can be either multifocal or bilateral. You can remove tumors and transplant that kidney. You'll see in the panel there that cancers are small, are low risk, and also certainly in the two top categories you could potentially consider transplanting the other kidney. So assessment at the time of retrieval is very important. One of the most common cancers in the Western world is that we are faced in donation is really brain tumor. And this study that was published this year looked at donors with confirmed brain cancer, and it investigated the outcome of 780 patients. And you will see there in the WHO grade that is a mixture of low and what is classed as high grade. Now, the important bit is this. There was no difference in survival between patients from non-donor cancer and the ones with a donor cancer. And actually, the risk of transmission is 3%. It's low. But here's the next interesting thing. They also looked at the willingness to use those organs and broke down by type of tumor, low grade and high grade. And you see that for low grade, the appetite for risk is there, but it's not so for high grade, despite the fact that the risk of transmission is very low. So what is this telling us? It's telling us that us as clinicians, we have some risk adversity for what we perceived as high-risk cancer. And that risk adversity, it's actually a lost opportunity to donate. This is a study done in Australia, published last year, where they looked at New South Wales over nearly 3,000 patients. And if you look at the bottom line there, is only 28 patients with donor cancer. Small numbers. But actually, very few donated. And they made the same observation, that 24% were declined based on transmission risk, and the risk assessment between that at the time of retrieval, then subsequent correlated with cancer registries, was very low. So we don't necessarily have the right information. And this comes to what we perceive as risk, not what is the actual risk. And they went on to do this study, which looked at nearly 1,700 donors. And in green are confirmed, in red you would see numbers of cancer that may be cancers. So there's a lot of unknown uncertainty there. And if you look at the numbers that did not donate, you actually can rescue a lot of organs, because 28% of those donors had a missed opportunity to donate. This is missed opportunity for patients to receive a transplant. Less so in the high risk. And what they concluded is that at the time of donation, the history is incomplete, and there's ways of optimizing that, but there needs to be a decision support to use those organs and perhaps access to data linkage. And the story evolves quite nicely because this is what they did. They said, okay, how can we make sure that we can maximize the utilization of those organs? So they implemented 3 models, one where they supported a decision, one they linked with data, and where they said, okay, decision to support and also increase risk of tolerance from the clinician. And they compared that with their model. So on the horizontal axis, increased qualities for patients, vertical, increased cost. And you'll see that really where you want to be is in that box there, at the bottom, where you want to have best quality, increase the quality with cost, low cost. And the one that makes sense is a simple decision to support donation and increase risk of tolerance. So in other words, we need to discuss with our patients and explain and we need to believe in what we're saying. So then, okay, but how high a risk can you actually take if you go down that route? And you will see from the green to the red, if you start with low risk, you're up to about 20% risk, you're actually in a good category, then the risk balance shifts. So this attitude of changing the risk behavior actually is not beneficial only for the patient, but also for the system because it allows more qualities and allows access to transplant to patients that don't have alternatives, such as liver, heart, and lung. But let me come back to one of the registry studies, and the Spanish one. You see there quite a number of recipients, 25,000, and they looked at the ones where deceased donation, where donors were diagnosed with malignancy before. And actually, with nearly just over 2 years of follow-up, there was no transmission, and that including higher risk cancer. The story is a little bit different for those who were diagnosed after transplant. Again, some of them developed the cancer. But the important bit is this, and this is a repetitive message. The number of cases that require cancer from the donor is really low. But also this study showed one thing, showed that the cancers we miss can potentially be diagnosed with a thorough assessment at retrieval. So this is in deceased donation, but a lot of transplants, particularly in this part of the world, is done with living donation. So what about this living donation? I think it's a different game because we have a detailed history available. We can actually undertake a very good assessment with early detection if possible. And certainly in the Far East, early colorectal cancer and gastric cancer are considered, for example, as curable diseases and not a risk. So you'll see there very much that living donation is not cancer risk-free, and these are the number of cancers developed in the US study that was recently published post-donation. Okay, so we have a risk. How do we put things in perspective? Well, we need to talk to the patient, we need to talk about the system and the health care. And I think communication with the patient is key because it's not a one-off. It's a continuous process. Reassess. Talk to them again once you know the information. And also present the risk of cancer at the time of listing. Do not bring that up at the time of assessment. And you need to consider a number of factors, including donor, risk, recipient-related factors, and of course, organ-specific factors. So the question is, how do we reduce uncertainty? How do we arm ourselves with best information available? Well, there's a number of things we need to do, and that includes reviewing history, histology, consult guidelines, and then careful inspection at the time of retrieval. And taking you back to what I said, this is what the information we can get for the colorectal cancer I showed you right up front, and consider what we do. And then when you're armed with those things, you go to the patient and you discuss the pros and cons. In our case, 2% risk of transmission versus 8% risk of mortality on the waiting list. And that's what you know what the patient will say. But it's not just about that. You need to put into the perspective if there are alternative treatments, pros and cons, and then provide the best information for the patient to make that decision. Okay, so we do have a cancer risk. How do we mitigate the risk? There are a number of strategies, and the 3 important ones are this. First of all, risk stratification. How do you know how high a risk that cancer is, what information you provide to the patient. And there are a number of guidelines out there. The one that is different is the Council of Europe because it does not put numbers. It just provides minimal, low or high risk or non-acceptable risk. So that allows you to place your cancer in the context. Now, no one will know this by heart, so I put this for you, the two guidelines we use mainly in Europe, one, the UK one, which is quite extensive, and certainly the European Quality and Safety of Organ Transplants Guide. So what do these guidelines say? Well, they're absolute no-goes where we shouldn't even consider donors, and these are highlighted here, both for CNS tumors and non-CNS tumors. But beyond this, we can consider individual risks. So very quickly going through some of those without necessarily looking at those: high risk, melanoma, breast cancer, colon cancer, important. There's also what is called an intermediate risk, where actually it could be acceptable to the patient to consider those, and the risk of transmission is somewhere between 2 and 10%. And I would point out for the CNS that what was classed as WHO grade 4, so the high risk level, actually is not that high risk of transmission. And of course, you're looking at a low risk where you can really consider those, or indeed minimal risk, where some of those cancers don't even play into this. So how do we sum all this bit up? Well, I think the important that if you go to the patient, you need to have a very clear view, and the key message is some of the organs may safely be used for transplantation. And the risk of cancer transmission needs to be balanced with the risk of dying on the list, but the risk of acquiring a cancer is really, really low. And this is not just the UK, it's the same for all the other registries published. And therefore, the potential recipient must have clear information and their wishes recorded and respected. What else can you do? Well, I think it's a donor evaluation, and I think the donor characterization is absolutely critical. You've seen from the previous talk the risk of transmission. So this needs to be an extensive search before the donor procedure starts in terms of history, documentation of any diagnosis of previous malignancies, laboratory tests for cancers, and imaging tests. And some centers in Europe do CT cases, CT scan in every single donor. And finally, the third bit, which is important, it's at the time of procurement. It needs to be done very thoroughly, and the surgeon has to do things with an increased awareness of potential cancer risk, potentially in the history, and properly examine all the organs and the chest and abdomen. And if there's a lesion, that needs to be excised, looked at by expert histopathologist, and the results communicated to all centers, because as I said right up front, the time is different. So the practical approach is simple. It's actually down to the retrieval team to make the diagnosis, undertake a histological characterization of tumors. It's desirable. The optimal management, it's different, and it's important how do we do that for the transmission. And if you do have a transmission, you need to have a registry where you collect all that information, because it's important to know in your own practice what you do and what is, rather than relying on international data. Okay, what happens though if we do have a donor transmission? And I think that's important in terms of informing the patients. And here's a study that was published again about last year, looking at a systematic review. You'll see very clearly that there's a number of cancers that will be transmitted, but you'll see on the far end column that by and large, they are fatal. So if transmission occurs, there's very little you can do. Now, just as a take-home message, the 1-year survival if a cancer is transmitted is 39%. Mortality is high. And it's interesting that median survival appears to be longer if the cancer is transmitted, is limited to the graft, or significantly shorter if it's disseminated. Now, what can we do? Is there any way of treating these patients? A number of approaches have been proposed, and you'll see here that none of them are very successful. You've got chemotherapy, you've got immunosuppression management, reducing it, and so on. and you've got potential retransplantation. So this is when you're told after implant immediately that there's a cancer. What do? Do you take it out and retransplant the patient or not? And I think that's a difficult question to answer, because retransplantation may be feasible, but complex depending on the time from diagnosis to retransplant, and may not necessarily change the outcome. And here you'll see some of the procedures that were, and the timing between diagnosis that spreads from 1 day to 24 months. But there's a possibility that cancer may not recur with quite good long-term follow-up. So it's a potential strategy you may want to consider for your patients. And here again, it's in the outcome in terms of survival. If it works well. If it doesn't, it's a disaster for the patient. Okay, so what is the level of evidence at the moment for managing donor cancer transmission? I think first of all, you need to investigate this very clearly and with a lot of detail for the tumor. I think the recommendation is strong, but the evidence level is low. I think it's important that when an organ recipient has a donor transmission, you need to inform all the other centers that have transplanted organs from that particular patient and consider discussion about risk about transmission and aggressiveness. Again, evidence is low. You could consider staging either in the form of CT or MR associated with a PET. I think, again, the evidence is low, but it's something that is strongly recommended. There is very moderate evidence for the benefit of retransplantation, but the recommendation is weak because we don't know if it does change the course and you expose a patient to a significant high risk of a retransplant. One option is to consider changes in immunosuppression, stopping MMF and azathioprine. The evidence, again, is low and the recommendation is weak. We are not sure it makes much of a difference. Or, similar, consider switching to mTOR at the same level of evidence. But one thing we can do is continue surveillance if we decide not to remove the graft with a CT. I think that should be done at regular intervals. How strong the evidence is, you can see here. So let me come back to my challenge at the beginning for you. This is a donor, and you've now seen what you can do. Would you now consider this case? Who would put your hands up and say, would you take this donor or not? Who would still not take this donor? There are a lot of unconvinced people. This donor is waiting for you. Take it or not. You should take it. The level of evidence shows that it's 2% risk of transmission. We did this in a 40-year-old woman with a liver that was successfully transmitted and no 5-year recurrence. Remember, it's not just up to you. You do bear the responsibility as a surgeon. This is where the buck stops. You are responsible. But your duty is to provide all the information you can so the recipient can make, together with you, the right choice that is relevant to their status. So, let me conclude this because it's an important topic. I think the risk of cancer transmission is actually a lot lower than previously thought. So those of you who would not have considered this case should reconsider your thoughts. I think it's quite clear that all donors with brain cancer are safe to use because the risk is low, and this includes donors who have had previous surgery. I think it's something we need to address. It's our risk adversity because we are reluctant and scared by the publicity, the bad publicity that it can bring to a program that if we do have a case like this. But if we change our risk adversity and we have a right way to approach the patient, things will work well. I think there's evidence that is not beneficial just for the patient, but it's also beneficial at systemic level because it does increase overall qualities for the vast majority of patients. And if it does happen, you need to have a registry with a clear reporting, governance and investigation process that actually can look at the source of the problem. Now, what we don't know yet, and I think this is why we still need the registries, is how we manage this. I think the management is unclear, and I think it will depend on case-by-case basis. Thank you.
Thank you, Dr. Gabriel, for very nicely giving us the mentioning the strategies and the guidelines of screening the potential donors so that we prevent the risk transmission, cancer risk transmission to the recipients. At the same time, not wasting the organs without proper screening. I will pass on the mic to my co-chair for further comments. Dr. Joel.
I think in our regions, South Asia regions, most of the transplants are done either in the private or the government sector. So the recipients, when I offered the kidney-bitten kidney, they said, you decide whether this can be done. So the question here is, there is a lot of financial constraints. And when we talk to the recipients about a deceased donor transplant, or for that matter, a live transplant, they always ask, can you give us a guarantee that the cancer will not be transmitted? I am unable to give that guarantee. It is not like developed countries. It is a developing region. So money is a major issue. Cancer treatment is a major issue. And this has to be taken into consideration in our setup, in our countries, regions of the world, when we offer a kidney with a donor who had a previous cancer.
So in our country, the mortality while waiting is more than 8%. So that changes the scenario. So if the risk of transmission is low, we would like to accept the offer. So that is it. A very good presentation, sir. Thank you.
So we have no, you want one question. Okay, Sultan, one question allowed. Microphone, Sultan.
Thank you for your very optimistic review of this process. I think you're absolutely right that we as physicians, we are very concerned about doing no harm, and sometimes maybe the pendulum has swung to the other side and we are too very careful. So I think your talk is very appropriate and extremely timely for all of us, despite country of origin. The point I would like to make is the relationship between immunosuppression and cancer. And there's no question that immunosuppression load is a contributory factor. But it's not a very simple cause and effect relationship. We found that drugs like cyclosporin has an immunosuppression independent effect on cancer progression. In a mouse model like a SCID-based mouse, which has no T cells, no B cells, no NK cells, if you give cyclosporin, you increase cancer metastasis. And you can block that metastasis with the drugs directed against TGF-beta. So there is an immunosuppression independent effect. Into the same mouse who is getting cancer with cyclosporin, if you add rapamycin, you have increased immunosuppression but decreased the metastasis. So you can increase immunosuppression load but actually decrease cancer. So I think we need to rethink about post-transplant malignancy. We need to rethink about the type of immunosuppression you use. And it may be that some patients who develop cancer, a switch from a CNI, you showed about MMF and azathioprine, but a switch from CNI to rapamycin may be beneficial because rapamycin is actually approved by FDA now for cancer mitigation, renal cell cancer mitigation. And also CNI, we always use CNI as a common word for cyclosporin and FK506, and they are not same. They are actually different drugs. CNI, cyclosporin is a little bit more cancerogenic and metastasis progression than tacrolimus. So I just want to make this point that we need to start rethinking about mechanisms of cancer progression. And I thank you again for a very nice, upbeat, and evidence-based summary for us.
Thank you. I totally agree with you. I think we also need to make a difference between donor-transmitted and donor-derived because that's a different potential management. And you're right, we do need more evidence in that field because, as I showed, there's not much. Thank you.
And now we would like to felicitate you and honor you with our love right over here from Kolkata's organizing team.